All right, we're getting started with our next session. Now, it is a speaker-packed session, so I've empowered Tina to run this like she runs her OR. Thank you, Tina. Tina sits on our steering committee, and we appreciate you, and we appreciate the Journal on Climate and Health.
Thanks, Mona. And thanks for your postprandial attention. I know it's hard. I always fall asleep right after lunch. It's those carbs. Maybe our vegetarian diet will help us some. So I'm the Associate Editor-in-Chief. I'm Tina Duhaime. It's really Anne Christine, but Tina's fine. And I'm the Associate Editor-in-Chief of the Journal of Climate Change and Health, which, unlike the Med Society Consortium, it has a lot of overlap, but it's also international in its scope, and we really try very hard to get international perspectives. So we were asked to just give some highlights. We had a meeting that many of you in the Med Society Consortium and other organizations participated in last October in New York City on climate and health. And we had a sort of a scholarship program for some of our overseas colleagues that are working on some of these issues at the front lines. Now, each speaker, I've asked them to stick to 8 minutes. We'll see how that goes. And our first several speakers are virtual because they are international. So I hope our folks can, our AV folks can help with that. And it's in the order that you see here. Dr. Ritu Parchure is from India, so is Dr. Ratika Samtani. Iris Blom is logging in from overseas as well. And Ilyssa Gordon's going to help me talk about our scoping reviews through the journal. And Dr. Parker from Vanderbilt is going to talk on her work with dermatology. So let's start with Dr. Parchure. The speakers can introduce themselves. I don't want to take any time away from their talks to do long introductions. So if our AV people can help us get started with Dr. Parchure, that would be great. Is that surgical enough for you?
Thank you, Tina. Can someone pull up the slide deck? Yeah, that's it. So a very short introduction about myself. I'm a public health researcher working in India. And today I'll be talking about this participatory learning approaches and how best can we use them in climate health education. Next slide, please. Yeah, so this is the organization. It's an NGO that I work with in India. We are based in Pune, and we work on different public health issues, including climate change and health, which is a recent domain that we have started working on. And as part of this work, next slide, please. We started working on the issue of doing community engagement for pushing for better health adaptation practices at the village level in India. And this case study is part of that work. This particular case study specifically focuses on this question: how climate change and health education can be leveraged to influence community level processes for better health adaptation. And this was done in Maharashtra, Pune. It's a western part. The Pune is situated on the western part of Maharashtra. That's there on the map for you. And we worked in 9 villages covering over 9,000 plus population. Next slide, please. The approach here was basically undertake dialogues with people. We call them as sharing learning dialogues and also action-oriented dialogues. And we adapted a number of classic PRA tools for undertaking these dialogues. Next slide, please. So these PRA tools were adapted specifically to the climate health context, and these were the tools that I'll be discussing about. Participatory learning using pictorial tools, case vignettes to shift the understanding from general to specific and theory to action, timeline to gain the temporal perspective of the changes, including weather and the health patterns, and listing and ranking. Next slide, please. So this is what these participatory learning using pictorial tools. The pictorial tools look like that. We call them as Chitra Katha. Chitra is image, and katha is story in our language. And so these were essentially handmade presentations using a storytelling method which did not require any technology per se, no projector, no laptop. Next slide, please. And this Chitrakatha prompted a range of discussions. It basically prompted people to share observations from various life domains and facilitated the discussion on local vulnerabilities and health linkages. So these are some of the examples that people discussed. In one of the villages, some ladies talked about depleting water levels, dysfunctional water purification system, and how that increased diarrhea cases among their children. In one of the village, 2 cases of recent deaths during a hot summer week last year were shared. And both of these people who died were in early 60s, had diabetes and hypertension, and had sudden death after a long day work in their farm. And this created a lot of alarm and interest in knowing more about heat-related illnesses and how they can protect their elderly. Then in one of the villages, when we were talking about vector-borne diseases and the impact of climate on that, people tried to understand this pathway by drawing similarities to the use of pesticides even during winter. The practice that they had recently changed because of the disrupted weather cycle. So this is how people related to their experiences and observations and try to learn climate change and health pathways through their experiences. Next slide, please. Then during that work, a diarrhea outbreak had happened in the project area. And we leveraged that to trigger discussions on heightened risk due to climate change, existing individual and systems level actions, and how these could be strengthened. So we adopted causal loop diagrams to highlight this issue. Next slide, please. We essentially drew this diagram to show what is the outbreak situation in that village. So we mapped the different risk factors for outbreak of diarrhea and typically how people respond in case of any outbreak, individual level, treatment seeking, the reporting to the health systems and health system level actions that are triggered based on that outbreak reporting. Next slide, please. We then also discussed about why and how climate change can exacerbate the situation and introduce some positive feedback loops that would help in controlling the outbreak. So here we talked about, next slide, please. We talked about these additional reinforcing loops, which will help in strengthening the response to that outbreak. So it was about the early reporting by private clinics and community health workers and regular feedback from the health system and collective actions at the village level. Next slide, please. The third tool was the timeline or the temporal mapping, and it was done through a game that we played called Situation Before and Situation Now. And we tried to get that information about the village from the villagers themselves, about all the parameters that have been listed on this slide. Next, please. Then after of 1 or 2 sessions like that, we summarized this information in the form of a chart. Here, that's the example of the chart, wherein we looked at the changing context. Can you go to the next slide? Oh, sorry, 1 slide back. Okay, so we talked about this. This chart basically discusses about what are the changing contexts, what are the health risks, what are the health consequences, and the likely solutions. And whatever was discussed during the previous sessions was summarized. And this chart was then, these villagers later decided that they will display the chart at the Gram Panchayat office. Next slide, please. The another tool was listing and ranking. Here we created a profile of the village, basically trying to trying the information about the existing situation of the social determinants of health and the healthcare access. And this information was obtained during the participatory dialogues that we had with the men and the women with these villages. And then we identified different issues, and then ranking and prioritization was done, and we planned collective action around these issues. Next slide, please. This was followed by action-oriented dialogues in smaller subgroups, wherein people came up with some micro-scale adaptive actions like how can early warnings be disseminated in the village using the existing mechanisms of the village that is available at the village level. How can they protect extreme heat at their own level, at the individual or the collective level? What can they do about the waste segregation? And they even passed a resolution to demand water quality report from the primary health center, so that they ensured water quality of the water sources in that village. Next slide, please. So to summarize, the learnings are as, can you go to next slide? So basically, these tools, because of the participatory dialogue, there was a lot of things that were added by the villages. So there was also some generation of new knowledge, which was linked to the theoretical pathways of climate change connection. And because of this grounding the science into the experiences, people could relate the science better, and it improved comprehension. We also realized that it helped extracting contextual vulnerability, especially during the sharing learning session, which is an important step towards health adaptation. And the process also initiated deliberations and discussions about micro-scale health adaptation actions. Next, please. It is generally believed that information and appeals, when combined with action plans, can increase people's confidence in their ability to act. So I would say that these participatory approaches do have a potential to increase self-efficacy of people, which is a very, not just self-efficacy, but also an ability to analyze their own situation and then discuss the action in light of that analysis, which is a very crucial set in climate health context, especially considering the dynamically evolving vulnerabilities and the uncertainties of health impacts. Next slide, please. Any community engagement, it is easier said than done. So there were many challenges all the way. Two important challenges were intersectionality and a lack of immediate direct effects that reduced willingness or openness to participate in the dialogue. The intersectionality, I would say, was mainly about the participation and the power for decision making. Marginalized migrant people, women, were seen, they had lesser representation during the meetings. One aspect we observed was young people were not, the representation was less, basically because many young people in these areas had migrated to urban area for work. And so they could not be included in these discussions, but we were very well aware that they hold quite a bit of decision power as far as individual or family level decisions, even village level decisions around health action. So these were some of the challenges. Next slide, please. And the only way forward could be continued engagement with different stakeholders over a longer period, and possibly strategies for better outreach and engagement will need to be explored as we keep engaging with these people. Integration with their existing community mechanisms, existing community forums, working on different health and non-health domains could be a possible way forward. Thank you. So I'm done with the presentation. If there are any questions that we would be taking immediately, or is it going to be at the end of the session?
We're going to do questions at the end. And I think that those of you in the audience who have heard other talks today see the correlations between what's happening on the ground there and some of the things that have worked locally here as well. The next talk by Dr. Samtani appealed to the planners of our meeting in October because it's a really very different approach than we think of as clinicians, but vitally important. So Ratika, let's bring you on. There we go.
Yeah, thank you so much. And thank you for inviting me. So I'm Dr. Ratika Samtani, and I'm an assistant professor at International Institute of Health Management Research. That's a very short introduction about myself. And today I'm going to talk about something very close to our hearts, and that is food. And especially that is something that we have just had, you all had lunch with. Okay, so next slide. I would begin by starting some quotations, like nothing brings people together like good food. We always believe that. There is no sincere love than the love of food. There's nothing in the world that good food cannot fix. And I only eat in 3 places, here, there, and everywhere. And since our love for food is so much, and when you talk about climate change, how does it affect us? So next slide. Yeah. So when we talk about climate change, we really need to consider talking about food security and nutrition. And going forward, next slide. It is very important to understand that the climate change negatively is going to impact, or it has started impacting the 4 main components of food, the 4 main pillars of food security. And that is something very important for us to basically understand that how is it affecting and what can be done. Next slide. Again, the climate variability and extremes are a key force behind the recent continued rise in global hunger. Next slide. This is something very important for us to understand that how are we visioning our world by the 2050? What is the future of food and farming going to be like? So by 2050, if you see, climatic impacts on food security will be unmistakable. There are likely to be 9 billion people on the planet. Most people will live in cities, and demand for food will increase significantly. Widespread impacts on food and farming are highly likely. There's going to be an average decline in yields for 8 major crops across Africa and South Asia, something which I'll be highlighting. Marine fisheries will also be affected. Of course, in the higher altitudes, fishery yields are going to increase. But if you see around the tropics, the fisheries yields in the tropics is going to decrease. Next slide. Can we go to the next slide? Yeah, same is the case with respect to heat and water, which may pass critical thresholds. Temperature increases of more than 4 degrees Celsius will endanger the ability of farms and ecosystems to adapt. Water cycles will vary different, and it will be very less predictable. And needless to say, we will need major innovations in how we eat and how we farm. Next slide. According to the NASA Goddard Institute for Space Studies, the average global temperature on Earth has increased by at least 1.1 degrees Celsius. It's not showing it's not showing here in the graph right now, but if you see the NASA's Goddard Institute of Space Science Studies, you will find how the temperature rise has increased. Next slide. And of course, the carbon dioxide in our atmosphere is at any time high than it has been at any time in human history. Next slide. Again, next slide. You can go to the next. Okay. Coupled with all this, with the rise in temperature, with the rise in carbon dioxide, there has been the problem that we are currently facing, especially in Africa and Asia, is that the number of extreme climate-related disasters have doubled since the early 1990s. If you see the incidence of drought, flood, extreme temperature, heat waves, storms, cold waves, lightning, thunderstorm, everything has increased. Next slide. And increased air temperatures and rainfalls levels have affected soil. Crops have started failing. Cyclones and hurricanes have damaged the crops. Too much of heat waves have actually led to drought-like situations, and because of which that has destroyed crops overall. Next slide. Next slide. So what do we know? Do we think that all this is going to impact our food? Is it going to impact how we eat? What do we eat? So is it going to impact the farming community? Is it going to impact the small farmers, the fisheries? Who is it going to impact the most? So next slide. This is something very important for us to understand, that whose food security and nutrition is most affected by changing climate. The world's 2.5 billion small-scale farmers, herders, fishers, and forest-dependent communities are the ones who derive their food and income from renewable natural resources, are the worst to be hit and affected. Next slide. If you look at this particular slide, you can easily understand that the impact of climate change will not be the same or will not be even across different food systems. Some regions are projected to have an increase in food production, if you can see the higher altitudes. However, generally, the projected climate change is foreseen to have a negative effect on food security, especially in the developing countries. Next slide. And also, the expected yield trends for rice, wheat, and maize at lower altitude derived from modeling over a range of temperatures and carbon dioxide concentrations are shown. And it is found that the orange markers, if you see that, it indicates that all these small grains are going to have a decline with respect to increase in global warming. Next slide. Yes, that's very well. It's self-explainable. Next slide. Yeah. Now let's look at the worst extreme of a situation. So what a 2 degrees Celsius and a 4 degrees Celsius warmer world could mean for global food security. If it's a plus 2 degrees Celsius warmer world would mean that 189 million people could experience levels of vulnerability to food insecurity greater than in the present day. If it is 4 degrees Celsius warmer world would mean 1.8 billion people could experience levels of vulnerability to food insecurity greater than in the present day. Next slide. And what would that mean for the different parts of the world? If you look at Bangladesh, Ethiopia, Cambodia, they are all going to face huge challenges with respect to the traditional foods they eat, with respect to the rice they eat, with respect to their livestock. Everything is going to have their own set of challenges with respect to the increase in extreme weather events. Next slide. There's a case study from Zimbabwe, though I've given the link. It shows that with the increase in temperatures, the drought-like situation that Zimbabwe is currently facing, a lot of the smaller grains, the people, they are not able to grow. Whatever the traditional food or the staple food they were having or they were growing, just because of the fact that because of these extreme weather events, they are not able to take on their staple diet. Next slide. Is a case of arsenic poisoning. With every rise in temperature, with the increase in heat waves, what's going to happen? The concentration of arsenic is also going to increase. Again, this is going to become a very big problem for what kind of water we are drinking. Next slide. So somewhere, yes, again, the case study from Africa, that shows that the indigenous sustainable farming systems have actually come out to play a very crucial role with respect to shifting cultivation, organic farming, agroforestry, mixed cropping. But more specifically, I want to bring your attention to the next slide. That is the traditional tribal farming of Orissa. This is something which I had discussed last time also, that the farmers of the Dongria Corn tribe in the southwestern parts of Orissa, they follow traditional practices that include a lot of diverse cropping. What I want to bring to your notice here is that millets used to be a staple food for tribals of Orissa. However, because of coming of rice and wheat and all these cereals, it was lost in translation due to modern agriculture. But these were the tribal people who realized the importance of highly nutritious and climate resilient millets, that the government of Orissa in India launched the millet mission in the year 2017. And it emerged as a consultation between the civil society and the government and the academia and the research, and they all came together and they pushed for millets, which are absolutely nutritious and they are climate resilient. So what this OMM or the Orissa Millet Mission did was that increased cultivation of native millet varieties which were climate resilient, and they ensured food security, they ensured nutritional security for the tribals. And what has happened, they have also included millets in the supplementary nutrition program under the ICDS, under the midday meal schemes. It has also started bringing about a behavior change in the community for taking more and more millets into their diet. This is very important. And the moment we include millets in the public distribution system, it's a game changer because it is going to combat malnutrition and it is going to help in mitigating climate change. Next slide. So this is something I just put forward for all of you to think about. You all must have seen a Venn diagram. So write down what brings you joy whenever you have free time. What brings you joy? What's your source of satisfaction and delight? Then what are you good at? Your skill, your resources, and your networks, and what work needs doing according to you? Climate and justice solutions. And what brings in between is basically your climate action. So if we are all, if we are all very conscious about it, we can actually bring out our climate action just by understanding this, a small part of this Venn diagram. Next slide. Thank you. Thank you so much.
So after I heard this talk, I went to the grocery store and found millet. And I'll tell you, it's really good. And it cooks up in half the time that rice does. And you can put it like salad over it, or it's great stuff. And I am now a millet fan. So I urge you to give it a try. So our next talk is by Dr. Blom, who will tell you a little bit about herself and talk about the work that she's done. Thanks, Iris.
Thank you so much. Hi, everyone. I hope you can hear me well. My name is Iris Blom. I'm a medical doctor. I come from the Netherlands, and I'm currently a PhD candidate at the London School of Hygiene and Tropical Medicine. Thank you very much for the opportunity to speak to you today. My presentation is on a systematic review my team and I conducted on greenhouse gas mitigation interventions in healthcare systems within low and middle income countries. Next, please. In 2020, the Lancet Countdown report notes that the greatest threat to global public health is the continued failure of world leaders to keep the global temperature rise below 1.5 degrees Celsius and to restore nature. Next. As you are well aware, climate change is currently impacting and expected to further impact health in a multitude of direct and indirect ways. Next. Secondly, climate change can challenge the capacity of healthcare systems to deal with already existing health issues now and in the future. Next, thirdly, the health sector itself contributes significantly to the climate crisis as a source of greenhouse gas emissions. Healthcare systems must seek to move towards net zero greenhouse emissions and thereby not contribute further to the climate emergency while adapting and planning to cope with the inevitable health impacts of climate change. Next. To dive a bit deeper into the impact of healthcare systems on greenhouse gas emissions, a global assessment of the environmental footprint of healthcare systems concluded that healthcare contributes around 5% of global greenhouse gas emissions. Emissions that come directly from healthcare facilities, which we call Scope 1 emissions, make up about 17% of healthcare systems' global footprint. Indirect emissions that come from purchased electricity, including cooling and heating, which are Scope 2 emissions, contribute another 12%. Finally, the largest share of emissions, namely 71%, has been assessed to come from what is known as Scope 3 emissions, coming from the supply chain, including the production, transport, use, and disposal of goods and services that the sector consumes. When viewed across all three scopes, more than half of the health sector's footprint is attributable to energy use. There is a large variation across contexts when it comes to the footprint of healthcare systems. In the US, emissions from the healthcare system make up around 8% of national greenhouse gas emissions. In a country such as my own, the Netherlands, this is 7%, and in a middle-income country such as Kenya, this is around 4%. We see more and more research about greenhouse gas mitigation in high-income settings. Next. There are, however, currently few examples of successful healthcare system transformations towards environmental sustainability in LMICs. LMICs, although historically contributing less to the total global greenhouse gas emissions, are expected to experience the most extreme impacts of climate change, whilst being the least resilient and least able to afford recovery. This underlines the urgency with which healthcare must adapt and transform into resilient health systems to adapt to these effects. Most action in LMICs is correctly around adaptation, especially in those settings with less ability and capacity to react to impacts and mitigate emissions. There are opportunities in various settings to cut emissions with potential positive implications for future health. Identifying synergies and co-benefits between mitigation and adaptation actions can create significant opportunities for LMICs to adapt their health systems whilst ensuring mitigation of emissions to avoid an adverse feedback loop in the future and advance the health system. Finally, to the relevance of this research within the current meeting, I would say that the commitment in many LMICs to climate action is remarkable. Having just come back from a field trip to Kenya myself, I witnessed dedication from my taxi driver all the way up to the president of the country. Combining this with the rapid economic development and growth that's ongoing, a unique opportunity presents itself for us from high income settings to apply humility and learn from the efforts that are happening in LMICs. Next. I won't go into details here, but this slide presents an overview of relevant recent global commitments that have been made to health system transformation. Next. Now to our methods. A systematic review protocol was published on Welcome Open Research following the PRISMA-P checklist. Relevant search terms were used to retrieve all primary research published in peer-reviewed journals between 1990 and March 2023. We assessed the risk of bias and quality of evidence. The final synthesis was performed with identified existing evidence around greenhouse gas mitigation intervention across all scopes of emissions. Next. After removing duplicates and then screening 19,292 unique records, we included a total of 22 studies from 11 different countries across the globe. The article spanned energy, waste, heating and cooling, operations and logistics, building design, and anesthetic gases. All interventions demonstrated potential for greenhouse gas reductions, cost savings, and positive health impacts. Due to the variations in measuring and reporting, the overall quality of evidence following the GREAT evaluation tool is low. Next. This world map shows an overview of the geographical distribution of where these interventions were implemented or modeled. I will shortly summarize the results found of interventions regarding energy, waste, and others, details of which can be found in the soon-to-be published paper. Next. Regarding energy, the articles underline that fully renewable or hybrid energy systems including renewable and conventional sources provide a reliable and sustainable source of electricity, especially in areas with intermittent or unreliable grid electricity supply. High initial costs are identified as a primary barrier. 7 articles reported positive returns over between 4 to 9 years, indicating that the long-term benefits of implementing renewable energy systems outweigh these costs. Adequate funding is therefore often crucial to support the initial setup of these interventions. Next. The results highlight waste segregation, composting, and material recycling to reduce greenhouse gas emissions, which is consistent with evidence from certain other sectors and high-income settings. Waste-to-energy technologies such as incineration, autoclaving, and microwave sterilization could contribute to greenhouse gas emission reductions compared to plasma melting or landfilling. It is crucial to consider potential unintended consequences, including pollution, when designing waste management policies to develop context-specific strategies to address the local socio-economic and environmental conditions. The limited information on costs and potential benefits of waste management interventions underscores the need for further economic analysis. Next. Articles highlighted that, in their specific cases, heat exchangers for air conditioning systems, reduced anesthesia usage, building design optimization, and improved surgical processes can lead to significant reductions in greenhouse gas emissions. Next. In conclusion, this systematic review provides the first comprehensive overview of existing evidence in peer-reviewed literature on greenhouse gas mitigation interventions for healthcare systems in LMICs. Gaps were identified across areas of emissions, such as the supply chain, sustainability, and scalability of the interventions, as well as lack of consideration of interactions with adaptation. Gray literature can be explored for further interventions. Going forward, it is vital that increasing greenhouse gas mitigation efforts are robustly monitored, evaluated, and reported to contribute to a strong evidence base to inform policymakers across contexts. Next, I would like to thank the 3 grants I have been privileged to receive and my family for making this research possible. And next, thank you very much for your attention, and also a big thank you for my research team and contributors from across the world. Thanks very much.
Thank you. We're going to get to the next one. This next talk is by Eva Parker, at Vanderbilt. And we really, really like this one because it's about something nobody ever thinks about, which is follow the money. So go ahead.
Thank you. Everyone hear me okay? So as Tina said, I'm Eva Parker. I'm a dermatologist at Vanderbilt University Medical Center in Nashville, Tennessee. I'm also an associate editor at the Journal of Climate Change and Health. And within dermatology, I co-chair the American Academy of Dermatology's expert resource group on climate change and environmental affairs. And I sit on the International Society of Dermatology's Committee on Climate Change. So thank you so much for inviting me to be here to present my study, which is climate change-related voting records of skin pack-supported members of the 117th Congress. And I want to start by acknowledging my co-authors on this study, which is Max Green, Ken Katz, and Marcus Bose. I couldn't have done it without them, so thank you. And while the baseline knowledge here on climate and health is immense, I do want to take a moment just to provide some background through the lens of dermatology. Because skin is the largest organ and the primary interface with our environment, the influence of climate change on skin disease and is multifactorial, and the pathophysiology is really complex, such that many cutaneous diseases and cutaneous processes are climate sensitive. And I think the most notable of which is thermoregulation, for which the skin is a key player. But in addition, skin cancer, infectious and vector-borne diseases, allergic diseases, autoinflammatory processes and their associated comorbidities, nutritional deficiencies, injuries, and UV-associated diseases are also climate sensitive. Additionally, skin plays a unique role in displaying cutaneous manifestations of systemic disease. So we also see that those systemic diseases are dually impacted by climate change. Importantly, too, environmental impacts, social justice, and health have key intersectionality, such that vulnerability to climate impacts disproportionately affects skin of color. Recent studies have demonstrated that the vast majority of dermatologists are in fact concerned about climate change, and that advocacy around the critical health, equity, and care delivery implications resulting from climate change is of growing importance to dermatologists. And accordingly, the American Academy of Dermatology adopted this position statement on climate and health in 2018, and it supports dermatology's role in mitigation efforts. And while the Academy has published over 70 position statements on topics relevant to dermatology, only a very small number of these statements relate to broad public health issues and societal issues. Even fewer present partisan policy considerations that impact population health, equity in the way that climate change does. So it's commonplace for the U.S. medical societies to leverage political action committees or PACs to support candidates whose policy platforms align with legislative issues that are critical to a specialty, and dermatology is no different. The American Academy of Dermatology's advocacy mission is to, quote, adapt to the shifting healthcare landscape while contributing to policies that protect the quality of dermatologic care. And the Academy considers skin pack contributions a key avenue to achieve this mission. In fact, Skin Pack donated almost $1.5 million to campaigns in the 2019-2020 election cycle alone. However, prior analyses have demonstrated incongruence between PAC contributions and legislators' voting records with respect to other societies' positions, such as that of the AMA on critical public health issues, and that includes tobacco, gun violence, and abortion. And in the context of broad climate impacts in dermatology, whether Skin Pack preferentially supports candidates taking pro-climate stances that align with the AAD's position statement was unknown to my group. So we designed a cross-sectional study to examine Skin Pack contributions by climate-related voting records. Contributions from Skin Pack to federal election campaigns between 2021 and 2022 were obtained from the Federal Election Commission, and individual campaigns of members of the 117th Congress were included. Key legislation was selected from the League of Conservation Voters scorecards from the 117th Congress, And bills were selected based on both their alignment with the AAD's position statement and their perceived relevance to healthcare. And of those receiving skin pack contributions, members' voting records for each of the bills was obtained from the U.S. Congress's legislative website listed here. And anyone who voted for passage of a bill that was considered to align with our position. We selected 4 pieces of legislation to examine: the joint resolution for congressional disapproval of the oil and natural gas sector, which nullified harmful Clean Air Act amendments such as limitations on methane emissions; Protecting America's Wilderness and Public Lands Act, which provides conservation of public lands in multiple states and U.S. territories; the Inflation Reduction Act, which is, as we know, landmark legislation to lower energy costs, increase cleaner energy production, and reduce carbon emissions by approximately 40% by 2030. And additionally, the Inflation Reduction Act provides assistance to Indigenous tribes and low-income communities. And then the final piece was the Senate treaty or Senate ratification of the amendment of the Montreal Protocol on substances that deplete the ozone layer. And we heard yesterday a little bit about this, but since stratospheric ozone depletion increases UV radiation, this is obviously has key implications in skin health. So what did we find? So Skin Pack contributed about $840,000 to 185 different congressional campaigns during the 117th Congress. And this table outlines those Skin Pack contributions according to the votes on the selected climate legislation. And overall, Skin Pack contributed more in total dollars to congressional members voting in favor of pro-climate legislation. And while this suggests alignment with the AAD's position on climate, what we saw is Skin Pack contributions to legislators voting against climate legislation and environmental bills was also substantial. And there was little difference in the median and range of these contributions. So what did we learn from this? Well, I think this analysis really suggests that other legislative priorities, such as reimbursement and scope of practice, likely influence Skin Pack contributions far more than the AAD's position statement on matters of public health and equity, like climate change. However, as climate change increasingly impacts dermatology in multifactorial ways, prioritization of contributions to candidates with favorable voting records on environmental legislation should be given. And I would argue that this is true of any society. Therefore, to better guide PAC contributions and to more effectively and ethically advocate on behalf of physicians and their patients, future studies really need to track alignment between monetary political contributions and congressional voting records regarding medical society stances on climate change. And so to this end, we have submitted an updated position statement to the American Academy of Dermatology's Board of Directors. And this update assumes a much more robust stance on the accounting and accounting of climate impacts in general in terms of dermatologic disease, impacts on delivery of care, and disparities in dermatology. It also provides strategic opportunities to establish climate change as a legislative priority, and that would help fulfill better the AAD's mission and duty to advocacy for care and access to care. So thank you so much.
Thank you, Eva. And as I said, our panelists will, I hope, will be able to get our remote folks back in a moment. I want to, along with the managing editor for this special issue, give you a little bit of an update on this because many of you in the audience are actually involved with this. And this is a special issue, what's called a virtual special issue of the Journal of Climate Change and Health, focused on the perspective of different specialties to try to answer the question, how is climate change affecting the patients you care for? Specifically, it's not about what are you doing to mitigate your own carbon footprint or environmental footprint. It's really about how is it affecting your patients. And where this stands right now is about, this is what's called a virtual special issue, which means as the articles are published, they get slotted into this virtual special issue. Once it's complete, it'll be closed and you'll be able to see everything together. But it's rolling admissions as they go through the peer review process. So right now, I believe that 4 of the specialty scoping reviews are published. We have about 4 currently in process being reviewed, and then we have another 10 or 12 that are finishing up their first drafts. So I see that Ilyssa's joined us remotely. That's great. So what is a scoping review? Many of you know, but I had to learn this because I had done systematic reviews, but not scoping reviews. And you've heard a couple like Iris's scoping review. These are protocol-driven literature reviews with the goal of giving an overview of what's been written in a field. They survey large databases. Typically, you require, it's very helpful to have a medical librarian on your team. And oftentimes you're looking at both primary research, sometimes other reviews, and also looking at gray literature, which is things like policy statements, or like Eva just talked about, you know, the policy statement of your own organization in that specialty, white papers, those sorts of things, sometimes government documents. And scoping reviews can be very, very broad, like, you know, how does climate change affect internal medicine? But because of a relatively short time frame, we wanted our teams to ask very specific questions about how climate change is affecting the patients in their care, that were a little bit less general and a little more specific. And I'll give you some examples of those specific focused questions. And what you're trying to learn is, what are the themes that people are writing about and talking about as to how climate change affects your specialty? What are the gaps that would inform future research? And what are some of our take-home lessons? So the author teams, again, because the Journal of Climate Change and Health tries hard to have a global perspective, we wanted authors both from high-income countries in North America and Europe to partner with international LMIC countries, underrepresented constituencies. We also wanted every team to have a trainee or junior faculty member because their voices are particularly important. And in some cases, residents actually took the lead and were the main authors of some of these, which was extraordinary. They're, you know, trying to be residents and applying for jobs and so forth. And it was beyond the call of duty, superhuman. And then we want, some of our teams from the larger specialties had quite a few people, and some of the other specialties had smaller teams. So the preliminary findings on a lot of these were presented at the October meeting, as I mentioned, which some of you attended, and some of those data are available online. There's also going to be synopses of these available as well. So which specialties? The published ones right now, I think there's one more in that list now since the slide was made: surgery, ophthalmology, and neurology. We're looking right now at palliative care, psychiatry and psychology, behavioral medicine, and respiratory care. And then there's a bunch more in process. And I think there's one more that I didn't include on this list. So these are some of the examples. It was really a lot of fun for us to see what questions people came up with. And these are just 2 examples. For the oncology group, it consisted of a medical oncologist, a radiation oncologist, and a surgical oncologist. And they wanted to know, what is the evidence that climate change and its associated effects are influencing the risk of developing cancer in the first place? How is climate change affecting the outcomes of patients with cancer? And then how is climate change affecting the delivery of oncology care? So they were pretty comprehensive about risk, outcomes, and delivery. And then the people that are doing the women's health, sort of OBGYN women's health group, they wanted to know 2 specific questions. How has climate change affected, what's the data about how climate change has affected the access to reproductive care? And then I just love this one. How has climate change affected attitudes towards family size choices? And so, you know, this is something many of us have kind of heard anecdotally, but they wanted to dig in and see what's been actually published about this in the peer review and the gray literature. So there are some emerging themes and gaps. And Ilyssa, are you going to, you're going to the takeaways, or do you want to talk about this, or you want me to do this one?
I can do this one. Can you guys hear me?
Yeah.
Okay. Thanks, Tina. So yeah, Tina and I have been working on getting papers and author groups together for the special issue, and it was a really informative day of learning at our conference where we presented all of these on the Sunday, which I know several of you were at, or in person or online. Some of the emerging themes that I saw coming out was that almost every specialty talked about heat, and there were papers that they identified in nearly all specialties. And the other emerging theme to me was very interesting was about nutrition. And we just heard Dr. Samtani talk about the role of nutrition, and it was a big surprise. I mean, heat is not a huge surprise that all of the subspecialties found a heat theme, but nutrition I was very surprised about. And nutrition ranged anywhere from micronutrients to malnutrition to poor diet and processed foods to insecurity, and how those factor into how a patient manages with climate change affected health impacts. Of course, one of the other themes is connecting to vulnerable populations, which we've talked about at this conference today and yesterday, and also access to care. So as Tina mentioned, one of the questions related to how do you access, dialysis centers when there's power outages and flooding and whatnot. And so, these are all really interesting themes that we found. One of the big, as Tina mentioned, one of the big aspects of doing these scoping reviews is that we were hoping to identify gaps. We definitely saw that there was a lack of studies from the Global South. And I would point out that to sort of make up for this, some of this is searching through gray literature, but there's sometimes a language barrier because a lot of the gray literature that could be helpful may be government documents and may not be accessible to all of the authors. The other gap is that there was variable disease groupings used in some of the studies. For example, in the cardiovascular disease group, some of the papers talked about, specifically ischemic heart disease or specifically acute MI risk, and others just talked about cardiovascular disease in general. One of the other things I want to emphasize about these scoping reviews is we were also able to include, as Tina mentioned, like specialties like surgery and anesthesiology, which are typically specialties that are looked at from the opposite perspective, the perspective of what are the contributions of these specialties to climate change. And so some of these papers are the first to put together and help us identify the gaps out there for what are the impacts of climate change on the health of a patient who will be undergoing surgery or undergoing anesthesia. So I think that's a huge takeaway as well. The good news is there are a lot of papers. As you all know, the numbers are increasing year over year and in different geographies. Again, similar to are seeing a lack of papers coming from the Global South, we do recognize that there are challenges in some settings to perform very rigorous studies because they may be in the midst of climate crisis more often than not. And in this case, we found it very interesting that some of the author groups chose to have some anecdotal stories included from less well-represented geographies. So that was a very interesting component. We saw that climate change can promote conditions for agricultural pathogens that are carcinogenic. Tina can tell you more about that one. We had an ophthalmology review that showed us that increasing the incidence, there's an increased incidence of cataracts and retinal detachment. And again, this access to care, so impeding access to basic surgical care. And next slide.
Yeah, so there, I think I can take over here. There were, because we're out of time, but there were some, am I off? Not on mic? Any better? Yeah, there we go. Okay, so we think the virtual special issue is a useful resource. It's a snapshot in time. It identifies some gaps, and we think that you will be able to use it for advocacy in your health system, in your hospital, in your state, in your local network, because there's some real data there, and it's compiled from, all over the world with an emphasis on, the higher income countries where the research is easier to do. We welcome anyone who wants to be a reviewer for anything in our journal. And if anybody wants to submit a project that you're doing for our journal, not necessarily for this special issue, and you're not used to doing papers that write up your work, please reach out to any of us, Eva, myself, Ilyssa, anybody else, Mark Lee Alexander, who's our editor-in-chief. We will help guide you. These scoping reviews took a lot of effort and a lot of meetings to help people come along. And stay tuned for new articles in this issue, because they will continue to come out and answer some of these big questions. So I think that's it for us. I think we have time for maybe like one question, if anybody has any, but for any of the panelists, I don't know, IT people, if you can put the remote panelists back up just for a second, in case anybody has a question for any of them. There's Ilyssa. How about our other ones? Are they still there? Ritu and you got there first. You get the first question. Go ahead.
One thing I would suggest is go back to www.superpolluters.com from the Center for Public Integrity from 2017. It was really a landmark investigation on it involves Southwest Indiana. But they looked at the carbon polluters and which ones were in common. And please consider frontline communities. And if you're researching CO2 emissions, include toxic emissions with that as well. And super polluters was a great template for that. Not that it went anywhere, but that's potentially, I think, where you're going to get some of the best momentum for frontline communities that can't change what's going on. Thank you.
All right. Well, that's the end of our time. Thanks, everybody, for coming to this one.